Good morning, everyone, or good afternoon if you're on the East Coast. Welcome to the Chronic Pelvic Pain Thinking Outside the Box webinar. Glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD and Pain BC in collaboration with the Canadian Pain Coalition. It's also made possible through the support of Community Gaming Grant Program through the BC government. As I mentioned, I'm Tanya, and I'll be moderating the webinar and handling the Q&A session today. And our presenter today is Dr. Catherine Allaire. Dr. Allaire is the Medical Director of the BC Women's Centre for Pelvic Pain and Endometriosis, and a clinical professor at the University of British Columbia's Department of Obstetrics and Gynecology. As a gynecologist, she is known across Canada and internationally as a teacher and mentor in minimally invasive surgery. Dr. Allaire is active in research related to gynecology and pelvic pain, and as a member of the Society of Obstetricians and Gynecologists of Canada, she's participated in creating national guidelines for the management of chronic pain. And I will hand it over to you now, Dr. Allaire.
Thank you, Tanya. Thank you to CRPD for the invitation to speak today. And I titled this Chronic Pelvic Pain Thinking Outside the Box because I wanted us to talk about a couple of things. One is the anatomic, physiologic interactions in the pelvis that can lead to pelvic pain, and to get a better sense of what therapies we can use to really address local pain triggers in the pelvis. But I also want to talk about how the brain plays a major role in ongoing pain and what therapies we can use to target those pain centers in the brain to get us better success in the treatment of chronic pelvic pain. So what is chronic pelvic pain? Well, it's pain in the pelvic area that's been there for longer than 3 months, and it can present with various types of symptoms. Often the pain is worse with menstruation and ovulation. It can cause pain with sexual activity, pain with bowel movements, urination, or it can be just pain with any movement, pain all the time. Some patients have pain that's very localized to one area, and some patients have generalized abdominal and pelvic pain. It can be central or lateral. And it has a huge societal impact. It's a very important problem in our society. It accounts for about 10% of referrals to gynecologists. 40% of diagnostic laparoscopies are done for pelvic pain. It's 12% of hysterectomies are also done for pelvic pain. The data from the U.S. is actually quite old. It's from 2003, so I'm sure that number has gone up since, because, for example, the Canadian data on just endometriosis alone estimated the cost per year, $1.8 billion per year. And of course, it has a huge personal cost with suffering, decreased productivity, marital discord, divorce, and also possible complications from all the tests and treatments that patients go through. How does it feel to the patient? Well, for a lot of patients, this is extremely difficult to understand what's happening. It's puzzling, frustrating, debilitating, creates conflict in their relationships, and very worrisome, and it's a true problem for many patients. And why is it so difficult to understand what's happening? Well, even for physicians that are trying to assess pelvic pain, it is a very complex area of the body. Just as lifting the hood of my car and looking under there, I would have no idea what I'm looking at, and would see many, many different knobs and structures that I wouldn't even be able to name. The same happens in the pelvis. As you can see on the right, there are a number of structures in the pelvis. There's visceral organs such as bowel, uterus, ovaries, tubes, bladder, but there's also muscles and bones and skin, of course, and nerves. So there's a number of things that can be involved in pain production there. This is a list of the possible diagnoses of chronic pelvic pain. You can see why physicians are a little overwhelmed with trying to figure out what's going on in patients with pelvic pain. And I think here I've only named the top ones. So in the gynecologic world, endometriosis for sure is one of the top triggers of pelvic pain. In the urology world, bladder causes, it can cause pain in a condition called interstitial cystitis. Irritable bowel syndrome is a very common cause of pelvic pain as well. And of course, then we look at the muscle pains, myofascial pains. We can have hernias, and we have even nerve pains. This is not a complete list by any means, but it's certainly the more common causes. I think it's important for women and actually anyone to understand the pelvis and understand the structures and the anatomy of the pelvis to get a better sense of what's really going on there. So I want to spend a little bit of time talking about the pelvis and the female pelvis. And this is really a normal pelvis on the right, a laparoscopic view of the pelvis, and I've labeled the different structures because I think that I'm surprised still about how little most women really understand about their pelvic organs. And so you see the uterus there, the ovary, the tube, in the front of the uterus, the bladder, and the back of the uterus, the area that's called the cul-de-sac, and then below the cul-de-sac will be the sigmoid bowel. And you can see on the left a cross view of these organs. Now, the menstrual cycle is an important process to understand as well, because the thing that's unique about the female pelvis is that every month women go through this tremendous physiologic change and physiologic process that can actually really cause some difficulties with pain and amplify pain in many ways. There's a huge change in hormonal status in the total body, as well as the inflammation process that occurs with menstruation, and that is what's unique about the pelvis in terms of its as a pain producer. So the menstrual cycle, this is a summary of all the changes that occur, both in the ovulation at the top. We can see the fourth line where the hormone changes occur in the body, and you can see that purple line where the progesterone goes up quite tremendously after ovulation. So the week before the menses, progesterone levels are extremely high, and that can also be a pain generator for some patients that are sensitive to progesterone. So it can lead to a cyclical pattern of pain that may not have nothing to do with the menstrual cycle, but purely with hormone production. And in the bottom line, we see what happens in the uterus and the endometrium that responds to the hormones, and that can be parallel to endometriosis a little bit, which I'll talk about later, as the endometriosis cells are really endometrial cells and respond in a manner similarly to, as you can see here, to the hormones. And every month there's an ovulation that occurs in most women that are in the reproductive age, and this ovulation process is a great physiologic, it's a miracle of nature really, but it's an incredibly complex physiologic process that also causes tremendous changes in the ovary. You can see that an ovary goes from being quite small to having this dominant follicle, which can be as large as 3 centimeters, and makes the ovary quite change in size dramatically from throughout the month. At times, after ovulation, the corpus luteum can actually have some blood in it, which it can, in some women, become a very uncomfortable process. The uterus responds to hormones, of course, and it also develops the lining of the uterus. And when the after ovulation occurs, there's this nice thickening of the endometrium. And when pregnancy does not occur, then there's a shedding of the endometrium with this huge inflammatory soup of blood and endometrium that's released and expelled. And that, again, in some women who are already in pain, can be an extremely painful process, even though it's a normal physiologic process. However, there are certain conditions in the pelvis that can cause a lot of pelvic pain, and I want to talk a little bit about those because they're certainly the more common causes of triggers of pelvic pain. So endometriosis is by far the most common. It's estimated about 10 to 15% of reproductive age women have endometriosis, but not all of them have symptoms. It's a chronic inflammatory condition of the endometrium, and essentially it's the endometrium cells that deposit outside the uterus, causing inflammation or scarring. And what's important to understand about endometriosis is it is an estrogen-dependent condition in the sense that it requires estrogen to cause pain. And so in the ages post-menopause and before menarche, it's unlikely to have symptoms of endometriosis. When on ovaries, it can produce cysts such as endometriomas, and then the diagnosis is usually can only be made definitively by laparoscopy, but I'll talk a little bit about that, laparoscopy, the role of laparoscopy in a few slides. So what kind of pain do endometriosis patients experience? Well, their pain is very cyclical. Certainly pain at the menstruation menstrual cramps is by far the most common symptom, and debilitating cramps are quite common. When I take history on patients, often they'll tell me that as teenagers they used to miss school because of nausea, vomiting, horrible cramps. I repeatedly missed schools as teenagers, and At times we're told that was normal and kind of a normal rite of passage to being a woman, and certainly if a teenager is missing school because of menses, it's not normal. Ovulatory pain can occur as well, so ovulation, as I explained, can be quite a painful process. There can be pain in the premenstrual period, and of course pain with intercourse, which tends to be a deeper hitting pain. There can be painful bowel movements, and then pain from trigger points, which are abdominal, myofascial sources of pain, which I'll explain a bit later. And then there can be the pain of infertility. Some women may have only that symptom of endometriosis, but it can be quite painful mentally, of course, and difficult to handle. How do we treat endometriosis? Well, we have medication, surgery, but also lifestyle changes. Many patients have told us that stress management, dietary changes, and exercise make a huge difference in managing their symptoms, and we certainly emphasize that in our clinic. Very important. So, do all patients need to have surgery to diagnose laparoscopy right away to diagnose endometriosis if they have those symptoms? Well, the answer to that is no. The recent SOGC guidelines addressing the pain with suspected endometriosis actually suggest first-line therapy with medications first, and then if that fails, to go on to second-line therapy with other medications, or to move on to laparoscopy for diagnosis and treatment. And then, of course, if these fail, to move on to reconsidering the diagnosis or considering a chronic pain management clinic such as ours. So why suppression of menstruation the first-line therapy? Well, because first of all, laparoscopy is not a cure for endometriosis, and secondly, we find that many times suppression of menstruation will lead to good symptom relief and good long-term management of the symptoms from endometriosis. What does it do? Well, it creates constant estrogen and progestin levels, and the level of estrogen can be very low or lowish, depending on the type of medication that we use. The lining of the uterus usually gets thin with all the medication options, so occasionally unscheduled spotting and bleeding can occur, but it's not a serious problem. The periods is stopped, and there's always a concern that this is unsafe or unhealthy, but on the contrary, for patients that are suffering with endometriosis, it's probably the better option, and it's completely reversible. Fertility is not affected. And then I often get asked about concerns about, is this going to cause cancer? And certainly in the case of ovary and uterine cancer, it protects against that. So what is a laparoscopy? Well, it's a minimally invasive surgery that's done through small incisions with a camera for visualization. It's done under general anesthetic. It's usually a day procedure unless there's a more extensive procedure that has to be done. And this was what a laparoscopic ports look like in our hands. This is our placement of our ports. So this is the belly button here, and there's 3 other ports, and they're about 5 millimeters in width. So the goal of a laparoscopy for pelvic pain is really to get a complete examination and palpation by laparoscopy to look for any subtle changes that may be indicating something like mild endometriosis, and to excise any abnormal area and send to the pathologist for evaluation. We don't like visual diagnoses of endometriosis because it has very subtle appearances at time, and other things can look like endometriosis as well that are not pain producers or pain triggers, so it's really important to get a proper diagnosis. And then we do a picture documentation of the findings to show our patients, which I find that they like quite a bit. So our goal at operative laparoscopy for endometriosis is to remove all the endometriosis lesions on the peritoneum using a fine needle to restore the normal anatomy, to release adhesions, such as scar tissue, to remove endometriomas. If we find cysts, we try not to drain them only, we try to remove the cyst to prevent recurrence. And also we remove even bowel endometriosis when it's symptomatic. This is a lesion of peritoneal endometriosis. I think my arrow is probably showing up, and you can see that I'm circling around the lesion. This would be behind the uterus at the left uterosacral ligament. And I thought I'd show you a quick little video of what it looks like to excise a lesion of endometriosis. So the left hand has the needle tip cautery. There's an electric current that goes through the needle tip. The right hand is pulling up on the lesion, and we basically lift it up and cut it out from the abdomen and send it to the pathologist. And therefore we know it's endometriosis. This is pictures of a cystectomy before. This is a smallish cyst in the left ovary, probably 3 centimeters, and after removal of the cyst. There are other conditions in the pelvis that cause pain. Adenomyosis is a common one that occurs in older women. I mean women after childbirth especially. It's kind of a cousin of endometriosis, where the endometrial cells, instead of tracking out through the tubes and implanting in the pelvis, actually grow into the muscle wall of the uterus, and this can cause quite heavy, painful periods in patients. Of course, adhesions are a concern, and we have patients that come see us with adhesions and convinced that adhesions are causing all their symptoms, and certainly at times they can. There's bands of scar tissue that are developed after inflammation, so the types of processes that cause adhesions can be previous surgery, especially when there is infection such as ruptured appendix, big bowel surgeries or pelvic inflammatory disease, as well as endometriosis surgery. Now, what's important to understand about adhesions is they're more likely to cause pain if they affect organ motility. So if a motile organ such as bowel, for example, or an ovary, which changes tremendously throughout the cycle, is bound down by adhesions, then that is more likely to cause pain. But there are many adhesions in the pelvis that do not cause any pain whatsoever. Another important thing to understand is that adhesions, post-surgical adhesions especially, are formed within 7 days after surgery and do not change after that. So I have patients sometimes see me 10 years after surgery and blaming and possibly wondering if the adhesions from their surgery 10 years ago is causing a new onset of pain, and it's unlikely that it would happen so late from the time of surgery, from adhesions anyway. Now at surgery we try to cut adhesions by laparoscopy if possible. We have to realize that even though we might cut every adhesion down, after some of them will reform, and therefore the overall bulk of adhesions will only be released by about 50%. Now, some adhesions don't cause pain. This patient has extensive adhesions of omentum to the anterior abdominal wall. The omentum is a non-painful, it's a fat pad essentially. There's really no nerves in it, and it doesn't lead to any pain to have the fat stuck to the anterior abdominal wall. However, this patient has an ovary that's trapped by adhesions, and therefore when this ovary ovulates and changes throughout the cycle, it's likely that some of her pain is related to this. Now, there's other conditions that produce pelvic pain, and they involve the other organs in the pelvis. Bladder is a big source of pain in some patients, and symptoms of interstitial cystitis would be urinary frequency, urgency, voiding at night, having a very painful full bladder, feeling like you have an ongoing bladder infection. And really the IC is probably related to sensitization of bladder nerves. Irritable bowel syndrome is classified as a classic symptom of bloating and change in stool frequency or consistency, such as alternation between constipation and diarrhea. And then with trigger points. So we see a lot of patients that have abdominal and pelvic floor trigger points that are related to their other pains. So a lot of endometriosis patients do develop abdominal wall and pelvic floor trigger points. And what happens is the nerves that come from the peripheral triggers, such as endometriosis lesions, travel into the dorsal horn of the spinal cord. I can see on the bottom right here. And at that point, there's a lot of connectivity with other nerves, and certainly very close nerves that travel out to the skin and the abdominal wall, and can create trigger points that are basically related to the internal visceral irritant. So we call that visceral somatic connections. So patients that have trigger points have tension and pain in their abdominal muscles. They may have sensitivity with light touch. There may be some actual thickening of the tissue, poor circulation, and often they avoid touch in that area. Even like jeans, wearing tight pants and all that will not be acceptable to them. Now, another thing that our physiotherapist has found in many of our patients is pelvic girdle pain, and she's taught us all gynecologists to do screens for pelvic girdle because it's such an important association with our pain patients, and we found it in many of them. It can present as pain around the front, sides, and back of the pelvis, and can be the start of the pain or the result of inactivity or change in posture from being in pain. And then the other assessment that we all do is the pelvic floor, of course. So we looked at the superficial, deep pelvic floor muscles and look for trigger points and tightness in these muscles. And we found that women with pelvic pain often have difficulty relaxing their pelvic floor muscles, have a higher than normal pelvic floor muscle tension at rest, and therefore they have pain and tension, difficulty relaxing these muscles, and certainly this tension can increase with any kind of stress, emotion, or other triggers. The pain cycle, of course, leads to sore and tight muscles, change in posture and movement pattern, decreased function, and increased pain. So this is the muscle pain cycle that our physiotherapist is very intent on working with and trying to break. So how do we reach a diagnosis for pelvic pain patients? I think that the important thing is to try to identify all the potential triggers in the pelvis and address those. And so in our clinic, we really have a very thorough approach to the history taking. Our patients fill out numerous questionnaires related to their history, to their bowel bladder symptoms, and also to their general moods. Anxiety, depression are very much coexisting with chronic pain and important to address. Then the physical examination is done very, very carefully with a single digit, looking for many trigger points in the abdomen and pelvis. But we also do an ultrasound-guided pain mapping where we actually do an endovaginal ultrasound in the office. You can see in the bottom left corner there. And with that ultrasound, we really see the uterus, the ovaries, the structures in the pelvis, and can touch them with the ultrasound and determine whether they're really particular contributors to the pain. All our patients get a physiotherapy assessment as well, looking for the other factors that I mentioned, and then we discuss the usefulness or need for a laparoscopy as a tool to further diagnose and treat pain. The physiotherapy assessment, again, is unique in our clinic in that we have the combination of the gynecologist, physio, and the counselor, of course, and I'll talk a little bit about that down the road here. But our physiotherapist assesses the back, hip, abdominal, pubic problems, and she addresses bowel, bladder, sexual issues, and teaches our patients how to start and increase their level of activity without causing flare-ups, which is a very important factor. So why are there some patients that respond well to standard treatment? For example, surgery for endometriosis or lysis of adhesions, or treatment for irritable bowel, and others develop chronic pain with disability. And how is it that some patients have pain that seems to spread to other organ systems? They start with menstrual pain, but then eventually they start having bowel and bladder symptoms and abdominal wall trigger points. So when pain starts going beyond the pelvis and involving many organs and not responding to treatment, then we're probably dealing with the concept of central sensitization. So this concept is, these pictures are actually borrowed from Neil Pearson's book, Understand Pain, Live Well Again, which I highly recommend for anybody that is in chronic pain or is dealing or has to treat anybody with chronic pain or has a family member in chronic pain, as it really explains these concepts very well. So we all have a pain alarm system. Our bodies are wired with a central nervous system is what we call the pain alarm system. It consists of peripheral nerves, which are the sensors, and these are what detect our initial event or injury, such as endometriosis. And the sensors become excited by the event or injury, and they send a signal up through the spinal cord and into the brain. And then they're interpreted by the brain. So the brain is where pain is felt. So it's all, pain, with no brain, no pain. So essentially, that's where it all happens. Unfortunately, the pain sometimes is not an accurate indication of what's occurring in the body, and sometimes our pain alarm system has become faulty and therefore oversensitized. And that's when we develop chronic pelvic pain, or chronic pain in general, but in this case we're talking about chronic pelvic pain. As the signals go up the spinal cord into the brain, they can be modified, they can be increased or decreased, and the factors that influence this modification can be mood, stress, environment, past experiences, or the meaning of pain. Also, what can happen in the peripheral nerves is that if they've been repeatedly traumatized or injured, or for example, monthly pelvic pain with endometriosis, these nerves can become oversensitive and start feeling pain with normal touch. For example, massage or light touch of the abdomen can lead to pain when the patient knows herself that this is not a really traumatic or painful stimulus, but yet it's causing pain. The analogy in the normal system would be like a sunburn. A sunburn is not a real damaging injury, but yet it can be extremely painful. The other thing we notice is that patients have cross-sensitization, partly because the brain has a very inaccurate map of the body, especially the pelvis. So there's many organs close by in the pelvis, and the brain has a very poor map of ovary versus bowel versus bladder. So they all map to a similar area in the brain, and therefore they all become intermingled in terms of our sensation. An example of cross-sensitization is brain freeze. When we swallow cold substance through our esophagus, we get this tremendous pain in our forehead. Well, how do those two relate? Obviously, there's a weird map going on in the brain there. So what we've noticed is a lot of our patients, for example, with endometriosis develop other symptoms related to their bowel, their bladder, their muscles and skin, and that's an effect from cross-sensitization. It's partly because in the dorsal horn in the spinal cord, where I showed that picture before, there's a lot of connectivity, and there's changes that occur in the spinal cord at the dorsal horn that lead to that cross-sensitization possibility. So in general, the whole nervous system becomes wound up. It becomes oversensitized, and therefore normal stimuli become extremely painful. And in the case of women, those stimuli can be things like ovulation and menstruation, which for some women are really not painful, but when you're sensitized, become extremely excruciating as experiences. So the problem with the faulty pain alarm system is it doesn't tell us really how dangerous the problem is. Is ovulation dangerous? No, it's not dangerous. It's a normal physiologic process. It doesn't tell us what the problem is or where the problem is, and that leads to chronic pain. The good news is that it's possible to make changes in our pain alarm system. The sensors are replaced every second. There's pleasure hormones that can block pain signals. The nerves are very adaptable and can be retrained, and the spinal cord and brain can act as gate control to diminish pain. There's many things that can be done and have been shown to be effective in calming down the nervous system, and these include lifestyle changes, mindfulness, meditation, CBT, pelvic physiotherapy, and of course we want to remove some of those ongoing triggers with medication or surgery. What's unique about our approach in our clinic is that we combine removing the painful triggers and calming down the peripheral nervous system with the central approach. And so if a patient clearly has ongoing triggers from something like endometriosis, and we can map it to their pelvis, then we will go remove the endometriosis, of course. However, if they have also ongoing triggers from ovulation and menstruation, we'll highly recommend stopping the menstruation and the ovulation to prevent that ongoing irritation from the peripheral nervous system. Sometimes use other medications to reduce the central sensitization, such as medical neuromodulators. And our physiotherapist can help manage the cross-sensitization of the pelvic floor muscles and the pelvic and abdominal muscles. So to break the cycle, it's important to learn about and understand pain, and really the education component is huge, and we have a whole day workshop where we teach patients about pain and understanding these concepts, and that in itself is very effective at starting the change of the central nervous system. Mindfulness meditation has been very well documented in terms of a very effective tool for chronic pain. I think there's an excellent series of by Nira Pearson on the CRPD website, which has the yoga, I think 5 video sessions with yoga and mindfulness, and I would highly recommend that for anybody that's in chronic pain. We recommend an anti-inflammatory diet. There's some literature to support it, but mostly because patients have told us that they just feel a lot better when they eliminate certain foods, especially if they have bowel irritability. Restoring sleep is so important. Sleep is disrupted in most patients with chronic pain, and it just sets up the nervous system for more wind-up when there's poor sleep. So it's very important to restore sleep, and we have a lot of information on sleep hygiene and trying to restore proper restorative sleep. And then, of course, our counselor is very effective at working on the self-talk and the negative self-talk that most patients have, and having more self-compassion to increase, to change that cycle that patients are in. Our physiotherapist addresses the bowel bladder issues. She uses techniques to decrease muscle tension and decrease sensitivity. She works on the general movement and stretches that are safe and rebalance the body. She also increases activity gradually with pacing and grading to avoid flares. And so what we recommend that most chronic pelvic pain sufferers do is get information about how their body works. before they have many years of suffering. Find out what's hurting. It's very important to finding out solutions for chronic pelvic pain. So we want to target teens especially. We find that that's a population that's been ignored a little bit and kind of suffers in silence. And so it's really important that they seek help and that really they don't go through this horrible monthly experience. If it is that to them, to stop the menstruation would be a good idea. It's important to work with your doctor and supportive family and friends and to invest in a good diet and lifestyle, and especially to reach out and share your story with other women. I think a lot of women with pelvic pain feel isolated. They feel that they're alone, that nobody else experiences what they're experiencing. And when we see these patients come together in our center and have the workshop and talk to each other, they start realizing that they're not alone. Their experience is not the only ones experiencing that, and they feel a great sense of relief and a great sense of community with the other women that suffer like them. And so I think that reaching out through pain support groups is very important for these patients. This is our team. We're very fortunate to have a wonderful team at the BC Women's Centre for Pelvic Pain. We have 4 gynecologists, a physiotherapist, a counselor, and 2 nurses. The website at the bottom is a good resource. There's lots of health information, patient resource information for patients and for physicians. So there's lots of links to different websites and also handouts. So our mission at the BC Women's Centre is we're a provincial centre for quality of life as affected by persistent pelvic pain. We emphasize advanced diagnostics, to try and really identify the pain triggers. We want to do knowledge translation, so research is a big part of what we're doing in the center. We like to educate our patients and the public and healthcare providers. We also want to be advocates for decision makers in the healthcare and other systems and provide support for community providers in the management of pelvic pain, endometriosis, and related disabilities. So we're very pleased that CRPD has approached me to talk today, and so to really talk about this model of care that we have, because we believe that it probably is the best model of care for chronic pelvic pain, and we hope that other centers across Canada get the funding and certainly lobby their government to get support to get a similar type of approach to this problem. These are just a few of the references that were used for this talk, and many of them are in our website, and I'd highly recommend going to any of these for more information about these concepts. And I think I went a lot faster than I thought I did, so that leaves lots of times for questions.
Great. Thank you very much, Catherine. That was a very good webinar, very informative.